So today we are going to discuss about the Alzheimer's disease. Contents are the following. Starting with the introductory part, it is a progressive neurodegenerative disorder which affects the older individuals and most common cause of dementia. The most common region which is affected is the medial temporal lobe. It happens due to the accumulating proteins, that is A beta and tau proteins, which is present in the neurofibrillary tangles. Further, these abnormal proteins can accumulate, or maybe due to overproduction they can cause the neuronal damage followed by the neuronal loss. There is marked cholinergic deficiency in the brain. Glutamate and neuropeptide are also affected. So the first which is affected is the acetylcholine. There is the depletion of acetylcholine. Death happens in 6 to 12 years of onset of the disease. The cause is complication of immobility such as pneumonia. The cause of the death, which is maybe due to the complication of the disease, that is a pneumonia or pulmonary embolism. Coming to the clinical stages. First stage is the preclinical stage, during which accumulation of the alpha, A, beta and the tau protein begins before any symptom appear. Second is the mild cognitive impairment, where there is episodic memory loss, that is the patient is going to ask the repeated questions. He or she misplaces the item very often. Third is the progressive loss of the functional abilities. Coming to the genetics history, why it is happening. Mutations in 3 genes have been identified, which are autosomal dominant in nature. First is the amyloid precursor protein, which encodes for the A beta precursor protein. Second is the presenilin 1 and presenilin 2. All 3 genes are involved in the production of A beta peptides, which are responsible for the neurodegeneration and loss of the memory. Further, presenilins form the catalytic core of the Y secretase. What is Y secretase? Y secretase is an enzyme where amyloid precursor protein is converted to A beta precursor protein. So it is the enzyme. Gamma secretase, actually it is not Y, it is gamma. A beta accumulates in the brain in the form of the soluble oligomers and amyloid plaques, and it is very toxic. Eventually it is affecting the neurons. Next, the apolipoprotein E, it also encodes the lipid carrier protein, lipid carrier protein. Further, coming to the neurochemistry, as we have already discussed, that there is a neurochemical disturbance due to the deficiency of acetylcholine. Further, it will cause the atrophy and degeneration of the subcortical cholinergic neurons. There is atrophy and subcortical cholinergic neurons की atrophy हो रही है. The selective deficiency of acetylcholine in Alzheimer's disease, and the observation that central cholinergic antagonist, example atropine, can induce a confusional state resembling the dementia of Alzheimer's disease and eventually given rise to the cholinergic hypothesis. Other than acetylcholine, there are more neurotransmitters involved, which is glutamate, serotonin and neuropeptides. What is the pathophysiology of Alzheimer's? There is pathophysiological hallmarks are the amyloid plaques. It can be extracellular or intracellular. Extracellular mein it is A beta and intracellular mein it is neurofibrillary tangles composed of tau. Further, the development of amyloid plaques occurs early and the tangles burden occurs over time. An autosomal dominant Alzheimer's, in which the A beta accumulates due to the mutation, thus causing its overproduction of the A beta protein. Amyloid plaques are highly ordered fibrils of the A beta, which is highly pathogenic. And the tau protein, which is responsible in the intracellular type of the pathological hallmark or the plaques, they are paired helical elements. or filaments. Post-translational modifications of tau, there is phosphorylation, then proteolysis, and then there is an increased aggregation. Both A, beta, and tau induce the neuronal dysfunction and death. Coming to the diagnosis and investigation part, it remains in the clinical diagnosis based on the presence of the memory impairment, memory impairment or other cognitive impairment, and not well explained by other disorders. So we have to look for the fluid markers. What are the fluid markers? That is changes in the A, beta, and tau in the CSF and plasma. Second is the structural MRI, where we have to look for the atrophy which is happening due to the decreased ACH. Then fluorodioxy glucose PET scan, where we have to look for the cortical hypometabolism, and PET scan, where we have to look for the amyloid or tau deposition. Coming to the treatment part, it is based on the two modalities. One is the treatment of symptomatic AD, and next is for the treatment of the behavioral symptoms. 3 classes of drugs are FDA approved. That is orally administered cholinesterase inhibitors first, second Memantine, that is NMDA receptor antagonist. Then IV anti-A beta antibodies, which is considered as the biologics. Coming to the first class, that is the cholinesterase inhibitors. Tacrine, which was first used, now it is not in use due to the cause of hepatotoxicity. Coming to the next, that is Donepezil, Rivastigmine, and Galantamine. It is widely used now. It is reversible in nature, and it targets the cholinergic deficits. Indicated for the symptomatic treatment of mild moderate dementia due to AD. It can also be used, these 3, Donepezil, Rivastigmine, and Galantamine, in neurodegenerative diseases including Lewy body dementia, vascular dementia. Further, we are going to see here the 3 different comparison between 3 different groups. That is, first, the basis of mechanism and enzyme inhibited. Donepezil is a non-competitive, cerebroselective, reversible acetylcholinesterase inhibitor. Rivastigmine is also non-competitive, carbamate derived, inhibits both acetylcholine and butyryl esterase. Galantamine is only the competitive one, selective for acetylcholinesterase, have the direct agonistic action on nicotinic receptors as well. FDA approved, these drugs are FDA approved. In case of Donepezil, it is approved in mild to severe Alzheimer's. Rivastigmine and Galantamine are approved for the mild to moderate only. Coming to the metabolism part, which is very important, those we have to not remember as such. Metabolism में CYP2 D6 and CYP3A4 are the 2 enzymes for Donepezil, which is responsible for its metabolism. Rivastigmine due to esterases, and again galantamine is metabolized by CYP2D6 and CYP3A4. Half-life of Donepezil is 70 hours. Rivastigmine is 2 hours, and galantamine is 7 hours. These drugs are well tolerated and used with cautions in patients of bradycardia and syncope. The most common side effects produced by these 3 drugs are GI distress, muscle cramping, abnormal dreams, anorexia, etc. Patient should be acetylcholinesterase should be stopped in patient who do not benefit by 3 months of the therapy. Second group is Memantine. It is an uncompetitive antagonist of NMDA receptors. Uncompetitive antagonist of NMDA type of glutamate receptors. They block the pathological NMDA receptor activation associated with excitotoxicity, permitting physiological activation associated with learning and memory. It is indicated in moderate to severe stages of dementia. It actually does not stop the progression of the disease, but it helps in the delayed deterioration of temporally. Temporally, it helps in the delayed progression of the disease. Then, adverse effects are mild headache, dizziness, constipation, and tiredness excreted by kidney, and it should be stopped if the patient does not benefit within 6 months of the therapy. Coming to amyloid immunotherapy, that is a biologics we are using here. In 2021, first FDA approved drug came, that is Aducanumab. It is a monoclonal antibody which is reducing the amyloid plaques. It is FDA approved via accelerated approval program, which allows early approval of treatments for serious conditions. It is indicated for mild cognitive impairment or mild demential stage. Given monthly by IV infusions and require MRI safety scans before the initiating treatment, and at 6 months interval में हमें MRI safety scan करवाना है. Coming to the treatment of the behavioral symptoms. Behavioral symptoms such as irritability, agitation, paranoia, delusional thinking, wandering, anxiety, and depression. Both cholinesterase inhibitors and memantine reduce some behavioral symptoms but do not treat them. Then SSRIs like citalopram showed efficacy for agitation in randomized clinical trial. Then atypical antipsychotics can be used. Then use of atypical antipsychotics in elderly with dementia is dementia-related psychosis. It can associate with the risk of stroke if given in elderly people. Then benzodiazepines used for the occasional control of acute agitation, but not recommended for the long-term use. So benzodiazepines can be used only for acute agitation. Then the new FDA-approved drug for Alzheimer's disease is Lecanemab, which is approved in January 2023. FDA approved for determining the individual with cognitive impairment. First, as we have seen in the pathophysiology part, it is divided into two, extrinsic and intrinsic. When extrinsic, that is A beta deposition is happening, and intrinsic में tau deposition. A beta में florbitapir, flutemetol, florbitaben are the three drugs, and in case of tau deposition is fluortaucipir. So it's tau is there in the name only. Coming to the overall summary, early stages of dementia may will be using cholinesterase inhibitors. If biomarkers indicate amyloid positivity, then amyloid immunotherapy. As the disease progressive, memantine can be added to the regimen. And for the behavioral symptoms, antidepressants or atypical antipsychotics can be added. Thank you.